So without further ado, welcome to tonight's COVID-19 briefing with Peter Drobac. I'll hand over to Paul, and I hope you enjoy the webinar. Over to you, Paul.
Thank you, Jo. Good early evening, Peter. Thanks, as always, for being our resident expert. I wanted to kick off with the UK because there are some early signs, at least 3 days, of either kind of flat or declining deaths. Now, you know, one swallow doesn't make a spring, and we're not sure if that is signal or noise, but there is at least some sign that there may be some tentative evidence of flattening in the UK, at least in terms of mortalities.
Yeah, that's right. So first off, just a reminder for everyone that especially in the UK, following the trends in the number of reported cases is not helpful because we're not actually testing very many people, only hospitalized patients, and now finally some NHS staff. So I would interpret cases without too much regard. Deaths and hospitalizations are more useful sort of markers for the overall dynamics of the epidemic. Hospitalizations we don't have access to, it's not publicly available, but Neil Ferguson, the epidemiologist who's been sort of the lead advisor and modeler to the government, says that rates of hospitalization are starting to decline. And as you mentioned, Paul, the number of deaths has at least over 3 days shown kind of a leveling off. A couple of days ago, the 28th was the highest single daily death toll at 250. Today, thus far, about 186 or so. So 3 days does not yet make a trend. I'd want to see at least 5 days before we could say that things are really leveling off. That's a sign that, you know, maybe that's a first sort of green shoot. I mean, again, we're still talking about a lot of deaths, and you know, and we know that the health system, especially in London, is still really overwhelmed. But we can hope so. Now, we've talked about how everything we're seeing today reflects something that happened 2 to 3 weeks ago, right? Because people typically who die of this disease die 3 to 4 weeks actually after they get infected, and they don't show severe disease until 2 to 3 weeks after they get infected. But if you think back to when all of our lives started to change and we had to start working from home, some of us may have had our kids out of school, things started, you know, slowing down. That sort of began about 2 weeks ago, and then the kind of more significant partial lockdown started about a week ago today. So this might be at the, you know, the beginning signs of some flattening of the curve. Fingers crossed.
So let's extrapolate that back, right? Most deaths occur within 30 days of contracting COVID. Is that there or thereabouts right?
3 to 4 weeks, yeah. Usually the incubation period is about 5 days before you show symptoms. And then people usually when they get really sick, they get really sick within the second week of illness. But deaths tend to occur 3 to 4 weeks after the time they first got infected. So if we're using hospitalizations and deaths as our proxy for changes, we have to really, again, what we see today is reflecting an intervention that we may have made largely a few weeks prior. Now, there's other stuff that can affect that, of course. You know, death rates may go up if the health system gets overwhelmed and people can't get a ventilator. But that's why it's a little bit on the early side to expect dramatic changes. But these early trends that we're seeing are hopeful.
Yeah, because so people who are tragically dying today may have got it a month ago, and a month ago is before we started taking any meaningful steps. So you would anticipate that the, you know, people who die in a week from now got it 3 weeks ago. That was also before we started doing any meaningful steps. So if it's slowing down now already, and that turns out to be true, that would be statistically interesting to try and explain, because we didn't really have widespread behavior change in the time frame that would reflect the deaths.
Yeah, that's right. That's right. And again, there's a lot that we don't know. There's a lot of uncertainty in all of these estimations, and that might be a good sign in terms of what, you know, our doctors and nurses have been able to do thus far in terms of, you know, helping folks to survive this illness, those who are severely ill. We hope so. But, you know, the Prime Minister said the other day, I believe it was yesterday, expect things to get worse before they get better. And I still think that is probably likely to be the case. We can expect the peak is still off by a couple of weeks out yet. So we'll have to wait and see what happens.
Okay, all right. Peter, I want to pivot a little bit because I think, quite correctly, we live in London, you're in Oxford, we're in the UK, and we're concerned to those people who are closest to us and in our communities and our friends and our colleagues, and that's something that we focused on a fair amount. I don't think we've had enough of a conversation about what's happening in the global south and the developing world. My home country, South Africa, has had a 21-day lockdown imposed. India had a 21-day lockdown imposed with very, very short notice. And it strikes me, knowing townships in South Africa as I do, that a 21-day lockdown for a person who's living in a corrugated iron shack in Khayelitsha on the outskirts of Cape Town in the Cape Flats, as winter is emerging, is a totally different experience, to say the least, but also the prospects of actually weathering that lockdown from a food perspective, from an ability just to stay in shelter. Those are not really places you want to stay for 21 consecutive days, and one's capacity to do so is different. So the first thing is, I fear that the next big story around Corona is going to be, the 10x number of deaths that we will see per capita in the global south and in the north. And also, just, do we need a different paradigm of public health intervention to try and treat this, when some of the measures that we're doing, when you presume people have homes, are available, which are just not available in the global south?
Yeah, this is what's happening now is unprecedented in terms of both the sort of breadth and scale, and also the intensity of the kinds of social measures that are needing to be taken to slow down the spread of this disease. And so there's not necessarily a playbook because a lot of us haven't been through this before, certainly not at this scale. But you're right, here a lot of the debate has been about sort of is whether the I think, as President Trump put it, the cure is worse than the disease, in terms of, is it right to be imposing these kinds of measures versus the economic pain and other kinds of things? And, you can look at that and sort of fall on the side of, well, it's important to save lives first and we'll figure out the rest later, right? The president of Ghana said, we know how to rebuild economies, we don't know how to bring people back to life. Great, that's fine. Now, in some other settings where you have communities living in, particularly in extreme poverty, that margin for error is so much thinner. And for all the reasons that you pointed out, and I think for many people watching today who are from the global south or who do work there, will be familiar with this. There's a very real possibility that the so-called kinds of lockdown measures, if they're not implemented in a way that is compassionate and there's not appropriate support, we could see a lot of lives lost from the interventions, even before we sort of get to the disease. And we're starting to see this in India in particular. The lockdown was announced with about 4 hours of notice. Hundreds of thousands of migrant workers and others without citizenship had no place to go. And there's sort of been actually probably the largest human migration in India since the partition happening as we speak. And so there are early signs that there is a significant amount of suffering and potentially death that's going to be attributable to that. That's something we have to be really careful of, because the worst case scenario here is kind of a worst of both worlds thing, right? So you imagine a scenario in which, because of a lockdown, a lot of people are suffering, are starving, are in some cases dying, and then you still see a surge in coronavirus infections that overwhelm a weak health system, and then you get deaths from that as well. So that would be, that would be a catastrophic scenario. Some of those settings um, that really has to be avoided. We've seen, again, there's no pay of food aid and their essential goods to the most vulnerable families across the country, and doing that directly to support the most vulnerable. And that's that's an example of the right kind of approach to help families get through this. We also don't know how long this is going to last, right? We're hearing here in the UK, this could be up to 6 months where we're having some degree of social distancing. That's a very realistic scenario. If you are a subsistence farmer or someone who's living right on the margins, maybe you can do this for a week or a couple of weeks, but much beyond that, it's going to get very difficult. And so I think in those settings, we do need a different playbook.
Yeah, because I've got these images in my mind of, and it really does go down to a recurring theme, which I think when we emerge from all of this, the quality of governance and the relationship between citizens and the state and the level of trust that citizens have towards the state, in particularly that the state will act on their behalf, is really thrown into relief. So I have this image in South Africa of people being told you're in lockdown, you don't have food. So you rush in large groups to your nearest store where you are cramming to get into the store because there's potentially a shortage of food, and a shortage of food really makes a difference. It's not like your cupboard is overflowing with supplies. Then the police arrive and tell you, don't stand so close next to each other, and then start firing tear gas and rubber bullets at 60-year-old grandmothers who are standing in line in a store very close to each other to try and get in to get food to give to their grandchildren, because the parents of those grandchildren died of AIDS and they are the elderly caregiver and they're exposed to it because their children may give it to them. So the whole complexity of what has to be done to care for people and what sorts of interventions are appropriate and what the police and law enforcement should be doing in these circumstances, as opposed to in Holland Park, London, just seems to me to be just completely just a different series of conversations and interventions.
Yeah, I think you're right, and it shows the importance of being prepared for this, and making it up as you go along, which sometimes has to happen in a situation that moves with the speed of this, can have real downsides. There's so many lessons around what we need to do next time in terms of preparedness, and I think that's absolutely a big part of it. We've seen a lot of the same stuff in terms of younger folks kind of resisting the guidance, and I think it's one of the reasons that we've seen higher numbers of young people infected and in hospital, even in places like America. That's being repeated in South Africa and elsewhere. But it's difficult. It makes me wonder a little bit, as critical as I've been of the UK government's, sort of lackluster and sort of slow response. Once they started to kind of get things in gear, there was a kind of signaling of what's to come and kind of rolling things out a little bit in a way that allowed us to start to get in a headspace and begin to prepare for a more kind of significant lockdown. And maybe there's some merit to that, as opposed to just saying, going from sort of 0 to 60 and saying everything is shut down, everybody stay home right now.
Tomorrow we're hosting Sir Tom Hallett-Hughes, who's heading the government's volunteer effort. As of today, 750,000 people have volunteered. I know that you're amongst those people, you and your wife, which on one level is just a staggering number. It's almost like a wartime mobilization. It's sort of this thing that the Brits seem to do well when a national crisis arrives. The sort of civic duty arises amongst people, which is extraordinarily important and admirable. The channeling of that rising swell of goodwill into actual assistance. You're a doctor. You've been in circumstances where I'm sure you could have dealt with a pair of helping hands or many pairs of helping hands when you've been at the front line. Are we going to be able to absorb this amount of goodwill and volunteerism? And is that going to save lives? Or might we just have this incredible civic upwelling of interest, but in fact, there'll be a mismatch in expertise to what may be required to save lives at this moment?
Well, I mean, first off, it's amazing and really heartening to see, and it just makes me so happy to see the way that people are coming out of the woodwork and volunteering to help. And in many cases, knowing that might be putting themselves at risk to do so. And it does feel a bit like a wartime footing where people are realizing we're all in this together, and that's great. The volunteerism effort goes far beyond just delivering medical care, right? So the 750,000 who signed up, there are also about 22,000 retired doctors, nurses, and other health workers who have sort of volunteered to come out of retirement and sort of be plugged in. So it depends on what folks are doing what, but I think a lot of the volunteers, as I understand it, are meant to be put to work helping to support the elderly and vulnerable in communities and providing food assistance and other kinds of support. And so there's lots of ways that hopefully folks will be able to be engaged in giving care and support in their own communities without necessarily going and having to, sort of try to staff a makeshift ICU in the new Nightingale Hospital or something like that. Talked last week about how challenging it's going to be just in terms of the organization of those new facilities. And what we've seen so far, or what I've heard so far from the critical care sort of community, is that help is not on the way, and they're building more beds and more ICUs, but it's going to be the same number of staff being kind of stretched across, at least until they can maybe mobilize these retired health workers. That's still going to be a stretch, but I think that, look, we're going to be at this for several months, and that period of isolation is going to be difficult. And so I think there are a number of ways that people can get engaged, and figuring out how to put all these people to good use is a good problem to have, I suppose.
I want to do a bit of kind of horizon testing with you. We're thinking a little bit about at the conduit of this kind of idea of building back better, of trying to think about what would be the deep lessons you'd learn from this really horrific and bracing experience, and how would you think in terms of prevention and preparedness. And so let's make you health czar for the day. And off the top of your head, we're sitting in Christmas of this year, and you're writing a paper to the Prime Minister of saying, to make sure that in March of 2021, if this were to happen again, we would weather it far better. What would your checklist of things be that we would all do to make sure that if this is the new normal, which hopefully it isn't, we deal with it so much better than we have under the current circumstances?
Sure. So off the top of my head, and I'll focus now just sort of on the health system as opposed to the broader system, and lots of other members can chime in their ideas, hopefully in an upcoming forum. So with regard to the health system, what I would say first is that we need to invest in the baseline health and resilience of our health system. I think what's become clear is that health systems that are weak or that are unequal or not accessible to all are going to really suffer. We know that our once great health system here has suffered from years of disinvestment from austerity policies, that there's a shortage of about 10,000 health workers, that the number of beds, and particularly ICU beds and ventilators on a per capita basis, are among the lowest in sort of Europe or the rich world, and sort of the list goes on. And all of those things are kind of vulnerabilities when you ever start to kind of face a surge. And so the first thing that I would say is we need to think in the long term about reversing that trend of disinvesting in the health system. It'll be better for us in the long run to have a robust health system that's working better, that's fully staffed and fully equipped, etc. Because these are the times that expose every one of your weaknesses, and I think that's probably already cost some lives, frankly. So that would be number one. Number two would be investing in surveillance and sort of early response. There were a number of things that I think in hindsight didn't go so well. I think the capabilities were there, and then maybe the action wasn't. But we know works early in an epidemic is having systems for aggressively doing testing and case identification, isolating or quarantining, isolating those people who are sick, tracing all of their contacts, everyone they've been in contact with through whatever the important period of time was, and then either following or quarantining them, and having a system that you can do this in a really rigorous way is so important. And being able to sort of have an early warning system that first there's a detection element, so you can detect a surge in new cases of a respiratory illness or something else that looks out of the ordinary kind of pattern, and then putting the system into place. Countries that did that well were mostly in East Asia, and mostly because they built those systems after SARS. To some extent in sub-Saharan Africa, we've seen that in some countries that have been living with or worrying about Ebola as well, Nigeria, Rwanda amongst them. They had those early warning systems in place, and so they were ready to respond quickly. And I think that's a measure for sort of every country. And we kind of call this the global health security agenda. And I think that's going to be really important in the future as well. I think there needs to be a deep dive into what went well and what went wrong in terms of the early response, how decisions were made, how consultations happened around scientific evidence. There appeared to be too much of a sort of groupthink and academic navel-gazing, a little bit of too much weight given to the sort of behavioral science group amongst those who were advising government. I don't know whether there was an influence of political decision-making or economic thinking over the public health. What was clear is that we went a very different direction here in the UK in the early months of this epidemic than most other places, than WHO guidance, and that sort of the evidence that we have over 100 years of fighting epidemics would suggest. So we need to understand what we can learn from that and what we would do differently next time. And then fourth and finally, you know, we won't be safe from this virus here or anywhere until we're safe from this virus everywhere. And there's been such a focus on country by country responses, and you know, I'm guilty of that as well. But we need to understand is that if this isn't under control in South Africa or Iran or in refugee camps, etc., we're never going to be safe here either. And so there needs to be a much greater focus on sort of international cooperation, coordination, collaboration, and supporting one another. And we've seen how that's not just around sort of guidelines and technical assistance, it's around resources, it's around potentially healthcare workers, it's around equipment, and all kinds of other things. Right now, that's not happening. We have a bit of a Hunger Games like scramble to get access to limited amounts of ventilators and PPE and things like that. In a perfect world, there'd be a much greater sort of global coordination around these efforts. And WHO has not been built to do that. That may be something we have to rethink.
Yeah, so that sense, I mean, I think it's very much within the realm of possibility that you see the crisis fade here in June, July, August, a sense of beginning to return to normalcy. And then you get a wave. I mean, we have already had the largest movement of human populations across borders in the history of the planet, driven partly by economic disparity and partly by climate. Mm. COVID can only accelerate that as countries are devastated, economies, there's a sense of joblessness, and as people look for a better life. You know, I mean, what has completely faded from the agenda has been the refugee crisis that up to now was, you know, everybody looking at people coming, you know, across the Mediterranean in dinghies. And this has to structurally increase the likelihood that this will happen, and therefore getting to the root of it, getting good treatment systems, getting good vaccines, and helping to approach this in a truly global sense has got to be at the top of people's agenda as the acute domestic crisis passes.
I hope so. I hope so. You know, history suggests that we're not always very good at that, that oftentimes once the immediate crisis is over, we try to get back to normal as quickly as possible and don't learn those lessons. Certainly that's been the pattern we've seen with past pandemics, but I think that we need to think about this as a wake-up call for a lot of the challenges we see looming in the next couple of decades. You know, migration certainly being one of them, and then linked to that, of course, the climate crisis. And this is in some ways a dress rehearsal for a big, complex global emergency. And we need to take lessons out of here that are going to help us address those challenges as well.
Our final question, Peter, for you is, it's the, the optimist in me keeps coming back to treatments and vaccines. And you just saw, Gates, I mean, there's now a $250 million just whipped up just by a couple of billionaires putting their hats in, whipping their hats around at a party. I don't mean to be trivial about it. It's a really, really important initiative. But has there been a moment in human history where you've seen more brain power funding and then the deployment of applied technologies, neural learning, machine learning, AI, to try and get on top of the rapid development of both treatments and vaccines? And is there a possibility that we could be entering a sort of unintended and by default a kind of global age of a golden age of treatments, of prevention, spurred by this very arresting human moment?
Could be. I can't think of anything else like it that I've seen. And, we've talked about the way that this virus spreads with sort of exponential speed or acceleration, right? This kind of, it's going on a logarithmic scale, and that's hard to kind of chase. The one place that we've seen anything close to kind of exponential growth has been this tremendous expansion or explosion of kind of the research, the R&D effort that's happening around the world. And that's happening because it's so important. It's happening because all other research is shut down because of social distancing and because there's unprecedented investment in it. But we're just seeing massive multiplication of efforts around the world at vaccines, at therapeutics, at, as you say, using AI and other technologies to deal with this, looking at early warning systems. Sort of the list goes on. It's kind of like a global Manhattan project, and a global Manhattan project to nuke the virus. And I think we'll get there, and that's really exciting. And I try to be an optimist as well. Certainly something that gives me hope is that with this much sort of, collective brain power and human ingenuity on the problem, there's no way I feel like we won't succeed.
Peter, as always, thank you very, very much. I know it's a particularly busy week for you because you also direct the Skoll Centre in Oxford, and the Skoll World Forum is occurring virtually. In normal circumstances, we would all be crammed together in one place, breaking bread and being a community of social entrepreneurs. So I'm very grateful that in addition to everything else you're doing, you've joined us tonight.
Can I just give a shout about that before we close?
Of course. Yeah.
So I know many of you are part of the Skoll community already and would be in Oxford for the Skoll World Forum this week, which of course was canceled. Our friends at the foundation have done an amazing job of pulling together the global community to put together a virtual forum that's happening this week. There are over 100 sessions that are being led by the foundation, by us, and by a number of different organizations. And the great thing is they're all open publicly. And so this has been one of those examples of a crisis turning into an opportunity to make the sort of forum much more accessible to people around the world. So there are a whole bunch of cool events happening all week. Go to skoll.org and you'll see the program for the virtual forum. Again, everything is accessible to anybody, and we'd love to see you participate.
And we'll be sure to shout it out to all of the members of the conduit and give it some extra coverage as well, both on social media and in our newsletters. So thanks for everything you do in that regard as well.
Yeah, pleasure.
Ciao. See you soon.
Bye, everyone. Thank you. Thanks, Paul.